Okay, welcome to Pharmacotherapy of Heart Failure. In this series, we'll be exploring the various use of different medications for the treatment of HFrEF or heart failure with reduced ejection fraction. We've talked about the pharmacotherapy of HFrEF, and let us now explore the cornerstones of therapy for HFrEF. The classes that are indicated for HFrEF include the ARNIs, the ACE inhibitors, the ARBs, the beta blockers, the MRAs, as well as diuretics. Now, don't panic because we'll be going through them later on in more detail. So you studied the ACE and ARBs, beta blockers, and MRAs already under hypertension. So I'd just like to point out that they are not only used to reduce blood pressure, they are also used here for a different purpose. And as we've discussed earlier, we needed agents to block the neurohormonal cascade. And so if you remember the mechanism of action of how ACE inhibitors, ARBs, and MRAs act, they all will contradict or block the effects of these neurohormonal cascades of the RASI cascade. And therefore, these agents are used to modify disease progression in the setting of heart failure. Now, beta blockers will block the adrenergic pathway, and that's where the sympathetic nervous system comes in. And so both of these groups of drugs will act in a complementary manner. So people used to think that ACE is enough, and then later on they realized that if they added on the MRA, there's an additional effect on the RASI blockade pathway, and therefore through the years it's been accumulating that we need to be using the ACE or ARBs as an alternative, the beta blockers and the MRAs. And the more recent addition of class of agents is the ARNI, or known as sacubitril valsartan, Entresto as its brand name. Now, diuretics that are commonly used in HFrEF are loop diuretics, and those comprise of furosemide and bumetanide. And we'll go through them a little bit more later. The most recent class that's been added to the cornerstones of therapy is the SGLT2 inhibitors. Originally, they were discovered and used for diabetes, for the treatment of diabetes. And it was of late that people realized that SGLT2s can also be used to treat HFrEF. Now, there are alternatives to the RASI agents if the renal impaired population needs to be treated. And as you would imagine, the ACE and ARBs are mainly used as vasodilators. And this is what we need in heart failure patients because they are highly vasoconstricted due to the neurohormonal cascades, right? So if you cannot use a RASI agent, then you'll be thinking you need to use something that's a vasodilator effect. And that's where hydralazine and isosulfide dinitrate come in. In the earlier days, before ARBs were even in the market, hydralazine isosulfide or HISDN combinations were used as an alternative when one couldn't tolerate ACE inhibitors or if they had renal impairment. Today, it's used either as an add-on, whether you needed maybe more blood pressure lowering, or as an alternative to the RASI agent. So it's dropped down in terms of the order of selection of drugs whenever you need to treat heart failure with reduced ejection fraction. So the key thing is optimization of doses of these RASI agents as well as the pulse or heart rate is very important. And if you remember, we were talking about the RASI agents in the context of blood pressure. We were talking about titrating medications according to blood pressure. However, in the setting of heart failure here, we're talking about targeting for optimal doses as long as the person can maximally tolerate. So blood pressure targets are no longer your goal. Instead, the optimization of doses or target doses are going to be your goal. The difference is now in practice, we generally don't go after target doses of beta blockers anymore, but more a target pulse rate for beta blocker usage. And that target pulse rate we go after is less than 70 beats per minute. So in a setting where either someone cannot tolerate the beta blocker or you can't push them up any further, for example, as Dr. Chang has mentioned, the blood pressure is too low, then you might be thinking about adding ivermectin because ivermectin is relatively blood pressure neutral and therefore it can be used as an adjunct to reduce heart rate further. If in a setting of atrial fibrillation, generally we do not use ivermectin because of the controversy that ivermectin is associated with new onset atrial fibrillation if you use it in the general population. And therefore, we would use digoxin on top of beta blockers if the person has concomitant AF. mainly because sometimes beta blockers may be poorly tolerated, and also digoxin can then additively help to control pulse rate in the setting of heart failure together with AF when they are concomitantly happening in the patient. So for people with HFpEF or preserved ejection fraction, we would usually go to treat the root cause, whether it's heart valve disease or amyloidosis. These are autoimmune diseases that require treatment. There should be aggressive management of comorbidities, whether it be hypertension or atrial fibrillation. Remember, as Dr. Chang has taken you through the series of atrial fibrillation, if poorly controlled or long-term in standing, can also be associated with new onset heart failure as your heart begins to weaken and fibrose. Very recent evidence with empagliflozin as well as sacubitril valsartan, as I mentioned earlier, has now started the scientific community excited because finally there were agents that could be useful in the reduction of cardiac mortality and reducing readmission in the group of HFpEF patients. Here I want to stress the importance of patient education and the role of the pharmacist. This is a very nice pictogram that is done up by the American Heart Association, and it gives you the traffic light zones of excellent, pay attention, and medical alert. And here you can get an idea of what a heart failure patient has to go through. And if you understand the lectures by Prof. Hui, you would understand that the backdamming of the fluid in the heart will cause high pulmonary pressures and therefore pulmonary edema. And that's how the dyspnea and shortness of breath with activity usually occurs. When it gets bad enough, they will not be able to lie down flat because that's usually when the fluid spreads throughout the lung. And it actually is better when they sit up, they can breathe better. So that's called orthopnea. Okay, sometimes they may experience swelling in the abdomen. This is when it gets systemic, and that is generally associated with quite bad fluid overload. So even though you may learn right heart, left heart failure, the body doesn't really quite behave in a compartmentalized way. So even though people have left heart failure, right, they can still get peripheral symptoms like swelling in the abdomen or a loss of appetite and sometimes even nausea. In very bad situations, you may get people with vasoconstriction all the way even to the brain. And I've actually had patients before who have had hallucinations because of this fluid overloaded state. So the very common, you will see swelling of the legs or the ankles. And why legs and ankles is generally because of gravity, right? So because if you understand the backdamming of fluids and high pressures, it causes the force of the hydrostatic pressure to be pushed out, and that's how the fluid comes out into interstitial spaces. So the places with less packed cells, for example, the ankles or the wrist joints, and sometimes the sacrum, the bottom of the spine, is where you get edema. And when you get pitting edema, you press into the skin. It takes some time to unindent itself. That is what we call pitting edema. Okay, so essentially if they put on weight quickly, now nobody gets fat in 1 to 2 days, okay, no matter what these girls like to think. If you actually put on weight for like suddenly overnight or over a few days of more than 2 to 3 kilos, it clearly is fluid retention. And generally fluid retention is what causes you to put on weight so rapidly. Likewise with dietary products that have got diuretics, right? If you buy over-the-counter dietary products that causes fluid like a diuresis, that's how you lose 2 or 3 kilos over 1 or 2 days. So no one actually loses weight so fast, so please don't be too happy when you lose too much weight. So in the contrary, in someone you tell them to take daily body weight every day, and they put on more than 2 to 3 kilos overnight, that is definitely a sign of fluid overload. And this is something that we will usually always watch out for and teach our patients to monitor for. So there are also very good educational materials like what is heart failure, what is basically how to live with heart failure. And these are important coping skills for our patients, because you can imagine that once you have heart failure symptoms, it becomes a very difficult to cope situation. And what you used to be able to do, right, you can no longer do anymore. Okay, so it's important that as pharmacists, when we see patients, even when we dispense to them, we should also be able to explain that the medications that we give them is not purely just for blood pressure lowering, but also it stops the harmful effects of the hormones in the body so that it can slow down the progression of the failing heart for these people. So why do we treat patients, and what are the goals of therapy by treating our patients? One is to improve the quality of life. You can imagine if they are not able to do their favorite activity, it can be quite a depressing situation to be in. We want to also reduce or relieve any sort of symptoms that they may feel, prevent or minimize rehospitalizations or getting to hospital because they cannot cope or they feel unwell, slow the progression of disease, as well as to prolong survival. So in all these areas, pharmacotherapy plays a very key role, and that's why the role of a pharmacist is extremely strong in the setting of heart failure. I've alluded several times to the European Society of Cardiology guidelines, and this is a very nice therapeutic algorithm of how HFrEF is being treated. So before all this, right, I would like to remind everybody that the reduced ejection fraction following an MI doesn't always get accompanied by symptoms of fluid overload. And so in order for you to have heart failure, you've got to also be presenting with symptoms of fluid overload, and that's why we call it HFrEF and not just a reduced ejection fraction. The group with post-MI reduced ejection fraction without symptoms of overload are considered the stage B type heart failure. Remember the stage A, B, C, D type heart failure classifications. Yeah, so those are actually stage B without symptoms. So we don't usually call them HFrEF, we usually call them STEMI with reduced ejection fraction. Here, I just want to stress this green box over here where you see the agents, and these agents are frequently touted the Fantastic Four. For those of you who are fans of comics, yes, the Fantastic Four pictures over there, just to remind you what the four classes are. The first class is, of course, ACE inhibitors or ARNIs. The second class being beta blockers. Third class, the MRAs or aldosterone antagonists. And the fourth class being SGLT2 inhibitors. Note here that while there are 3 different SGLT2 inhibitors available in Singapore, only dapagliflozin and empagliflozin has been studied for heart failure. Now, the fifth group in this green box over here is loop diuretics, and is usually used for only fluid retention situations. We don't usually use them permanently for the whole life of our patients. As long as we can down titrate or stop them, we would sacrifice them in order to up titrate the ACE inhibitors or the beta blockers or MRAs, as well as dapagliflozin and empagliflozin. You can see, and as you have studied in hypertension, you know that these classes actually all reduce blood pressures. And so therefore, if you try to up titrate or optimize the doses of these agents, you would also inadvertently drop the blood pressure. And therefore, in order for you to have more room to increase the doses of these Fantastic Four, you've got to make room by reducing the dose of diuretics as much as you can. Sacubitril valsartan actually requires quite a big mention here. And this moiety started to enter practice somewhere in 2019, 2020. And you can imagine that how important pharmaceutical chemistry is, right? Just by discovering this moiety called sacubitril, you can create this moiety called the ARNI, or the sacubitril valsartan moiety. So we know all the beneficial effects of all the RASI agents, right? They will reduce cardiac fibrosis, hypertrophy, reduce the risk of arrhythmias. It can increase vasodilatation because of the way that it acts on the RASI cascade. Additionally, because sacubitril can then inhibit the action of neprilysin, and neprilysin actually breaks down the beneficial peptides like natriuretic peptides, which are natural vasodilatation type of peptides, right? So because it inhibits neprilysin, it causes the accumulation of the good proteins, and that also leads to natriuresis, leads to vasodilatation. So this ARNI is really something that's changed the world. And of late, there were studies that show that it reduces mortality, both in HFrEF as well as in people with HFpEF that have got EF that's less than 50%, or rather the HFmEF population. So the sodium glucose cotransporter 2 inhibitors were originally used in diabetes, as I mentioned, and they are no longer just indicated for diabetes purely anymore. How they act is basically that it blocks the reabsorption of glucose from the renal tubules, and I shall not steal the thunder for diabetes next year for year 3, so I will not talk very much further about how it acts to reduce the glucose in the body. However, I just want to point out on the right hand side that it's got other effects as well. It's been associated with increased natriuresis and also the change in how the tissues handle sodium. And as a result, it's been associated with very nice renal effects as well as heart failure, reduction of new onset heart failure, as well as readmissions due to heart failure symptoms. And so if you look at how the cascade of events occur downstream, you can see how it can potentially act in heart failure as well to actually reduce the symptoms due to heart failure. So in the earlier days when SGLT2 inhibitors first hit the market, everyone was really afraid about the euglycemic ketoacidosis situation. Essentially, the question was started to be asked about when SGLT2 inhibitors can be commenced. Now, as long as the patient is stable, the SGLT2 inhibitors can be started right after the patient is out of decompensation. How do you know when the patient is out of decompensation? That's when you ensure that there's no need for any use of inotropes, which helps the heart pump harder, or IV vasodilators within 2 days of the use of SGLT2 inhibitors. You have to make sure that the IV diuretics are no longer needed. And if needed, the chronic oral loop diuretics should be prescribed or administered to the patient. And you have to ensure that the blood pressure is above 100 millimeters mercury in order for you to consider that they are stable enough to be started. So what was this euglycemic ketoacidosis that we were worried about? Now, when SGLT2 inhibitors first came into the market, there were a lot of people who were readmitted due to ketoacidosis. It was later found out that potentially the people who had diabetes that tended to be on insulin or some sort of insulin secretagogue, especially if they're high dose insulin, there's a setting where you reduce the insulin dose too much, and also in a setting where you are either fluid or calorific curtailed intake, right? That's when you actually get to the risk of DKA or diabetes ketoacidosis, and you can actually be euvolemic as well. So people have asked the question whether people like our Muslim colleagues who undergo Ramadan, will they be at risk? There didn't seem to be increased signals in the meanwhile. So as long as we are clear that we do not use SGLT2 inhibitors too fiercely, which make sure that the patients are out of compensation, or if they are having a raging pneumonia or an infection, don't start them. We should be fine. If you are undergoing a stress state like that, you should not actually be thinking about SGLT2 inhibitors. In fact, there were people who purport to ask to hold off SGLT2 inhibitors if you need to undergo stressful activities like a surgery or prolonged starvation. Like when you go through a major surgery, you have to be starved for several days. That's when the SGLT2 inhibitors should actually be withheld. And in those situations of stress, they should not be started. With this slide, I wanted to stress the semantics of dosing and indication between the three SGLT2 inhibitors. At this time, it's not quite a class effect that everyone needs to remember, that they're not completely synonymous or interchangeable with one another. I've stressed earlier that only dapagliflozin and empagliflozin have been labeled for use in heart failure with reduced ejection fraction, and they actually do not need to have diabetes in order to use SGLT2 inhibitors. This was actually found in people with high cardiovascular risk as defined by a history of ischemic heart disease or hyperlipidemia. And these studies showed that the SGLT2 inhibitors like dapagliflozin as well as empagliflozin were able to reduce hospitalization due to new heart failure and also reduce the onset of new heart failure for people with high cardiovascular risk. So this was actually quite an important finding in the scientific community, and that's how SGLT2 inhibitors, DAPA and EMPA, became the fourth pillar of the Fantastic Four. So I just wanted to stress also, if you compare the doses of the SGLT2 inhibitors, just focus on empagliflozin for now. The dosing for diabetes for empagliflozin actually goes up to 25 milligrams. However, if you're using it just purely for heart failure alone, for high cardiovascular risk, you would only use 10 milligrams. That's less confusing with dapagliflozin because for both diabetes as well as heart failure, you use 10 milligrams. It's just that for the diabetes, you can can actually start it lower at 5 milligrams. They are all consistently useful for diabetes kidney disease, except empagliflozin has not been labeled for diabetes kidney disease yet. And all the drugs have been associated with a reduced progression of kidney function. You know, it can slow down kidney function worsening with time. Okay, so there are some little notes at the bottom on renal adjustment. I will not belabor the point at this time because you'll be undergoing kidney in the next semester, and you'll be learning a lot more about dosage adjustments according to kidney function in the next semester. With this slide, I wanted to go through to summarize all the agents that we use as foundational therapies in HFrEF and why do we use them. So let's start with the ACE inhibitors, or I put ARBs in brackets mainly because the ARB should be rarely required these days since we've got the ARNIs in use. The only big thing about the ARNIs is that it's extremely expensive, so that is the only thing that's stopping its widespread use. But I hear that come January, there's going to be a lot more subsidies in place, and so let's all wait for that to happen so that our patients can get more access to it. So the three main groups of functions that we use our pharmacotherapies for, I've listed above. They either reduce or relieve symptoms, or they prevent or minimize admissions, or they prolong survival. And for the ACE inhibitors, they've been associated with prolonged survival. With the ARBs, I'm not as convinced because not all the ARBs have been also well studied. If you ever need to use ARBs for HFrEF per se, I would stress on the use of valsartan or candesartan. I think losartan is commonly used, but I am not convinced that evidence-based wise it is all that useful, mainly because the only study that looked at it comparing with ACE inhibitors in heart failure patients, right, they didn't even manage to meet statistical significance with respect to non-inferiority. In other words, if you really need to choose an ARB for heart failure, I would either go with valsartan or candesartan. For the ARNIs, as we've mentioned earlier, it's extremely costly. The subsidies are coming in January. So if you today have no difficulties affording ARNI, which costs some $8 to $9 a day, I would say ARNI is going to be the drug of choice because it's shown superiority compared to ACE inhibitor. Although I have a little bit of problem with the study design of that particular study because the ACE inhibitor was actually not optimized, and that's not how we should be treating ACE inhibitors. Anyhow, the studies have shown superiority of ARNI over ACE inhibitors with respect to reducing deaths due to heart failure, and therefore ARNIs became the force to take over the world. And you can see that ARNIs have got the same effects. They either reduce symptoms or they prevent hospitalizations, as well as prolong survival or reduces mortality for heart failure with reduced ejection fraction. Now, the same story repeats for the beta blockers. Again, is benefit for all three functions. However, I'd just like to point out that for the beta blockers, right, there are only 3 beta blockers that we should be using for heart failure, and they are bisoprolol, carvedilol, and metoprolol XL. And this is something that I want all students to know very well. These are facts that all pharmacists must know very well. For the MRAs or aldosterone antagonists, the same story recurs. There are all 3 functions you fulfill. And in Singapore, in the restructured hospitals, you use a lot more of spironolactone because it is generic, whereas eplerenone is still branded. I'll mention at this time that the eplerenone drug, this particular drug, has been studied in post-MI with reduced ejection fraction, not purely just in heart failure alone. So logically speaking, eplerenone actually has got the most data, but because it's expensive, it never really caught on in Singapore, and therefore all the experience we've had mostly has been with spironolactone and not as much as eplerenone. One thing to mention is generally the SGLT2 inhibitors. As I mentioned earlier, I've struck off the canagliflozin, and only DAPA and empagliflozin has been studied or labeled for heart failure with reduced ejection fraction. And again, all 3 functions have been fulfilled by the SGLT2 inhibitors. And then I put the poster of the Fantastic Four at the side to remind you that's why they're the Fantastic Four, right? For the diuretics, because it has not been associated with prolonged survival or reduced mortality in HFrEF populations, but certainly they're useful in reducing symptoms, right? Because clearly it clears congestion due to fluid overload. And the commonly used agents in Singapore are furosemide and bumetanide, and these are the loop diuretics. We didn't talk so much about them during hypertension, mainly because loop diuretics are not commonly used for hypertension, whereas if you recall, the thiazide or thiazide-like diuretics are commonly used for hypertension. Now, in this setting of heart failure or fluid retention or fluid congestion or fluid overload, sometimes even in CKD, you might see the loop diuretics as well as metolazone used quite frequently. Now, metolazone is a thiazide-like diuretic as well. And interestingly, unlike the thiazides, which are dependent on renal function. So if your renal function is too poor, it doesn't get secreted into the renal tubules, right? Whereas for metolazone, you can actually use it even until quite poor renal function, even in stages of creatinine clearance less than 30. Okay, there are other classes of agents that used to be used from before, which are amiloride as well as triamterene, and these are the potassium-sparing diuretics. However, I think they failed to advance their market share as opposed to spironolactone, and therefore today we've no longer used these potassium-sparing diuretics anymore. So for the purpose of practice in Singapore and for your exams, you just need to know furosemide, bumetanide, and metolazone very well. We rarely use thiazides for fluid overload for the simple reason that it's just prescribing habits. We generally use loop diuretics a lot more frequently for fluid retention. It could also be because of the fact the way that they act, the mechanism of action, that they are more effective in managing fluid overload than the thiazides. Lastly, the group of ivabradine is not quite one of the fantastic four, but is worthwhile mentioning because it's used as an adjunct to beta blockers, and I mentioned this much earlier on in the earlier slides. It usually is not used alone unless you really have no choice, but you cannot use beta blockers because the mortality benefit has been shown on top of beta blockers. And again, we're going after target heart rates of less than 70 beats per minute. Now, this is a busy slide and I don't want to talk you to death by reading off the slide. You can probably read the information yourself. I'd like you to pay attention to when to initiate these agents. Now, there are not that many agents that we can initiate in the acute setting when a person comes in with decompensated heart failure or when they're very unstable and very, very fluid overloaded. Clearly, common sense is that when they are overloaded, you have to use the loop diuretics, and therefore the loop diuretics, whether it be the IV form or in the oral form, are what you generally use as first line whenever patients come in with the fluid overload or congestive symptoms. So the other agents like the beta blockers probably would be used during admission and when stable, because remember, beta blockers, while we said that they are useful for chronic heart failure, they can suppress the systolic output, right, or the heart function or cardiac output, right? So when a person is very unstable and the overload has not been cleared, the use of beta blockers in such acute states can actually precipitate the pulmonary edema, which you don't want to get, or worsen the fluid congestive states. And therefore, we usually use beta blockers or up-titrate them, right, when the patient is out of overload problems. The other agents, like the RASI agents, for example, the ACE, the ARNI, as well as the MRAs. Now, you need to pay a little bit of attention when you are acutely diuresing the patient in the inpatient setting, because when you diurese the patients, you end up having a lot of concentration of the electrolytes in the body, and sometimes the serum creatinine can rise, or it can precipitate the state of what we call acute kidney injury, because you've gotten rid of a lot of fluid, and therefore acutely the kidney appears like they're being injured. Now, when you do that and your fluid contracted, when you use ACE inhibitors or ARNIs or MRAs, what happens is that you also reduce the efferent arteriolar constriction, if you remember the mechanism of action. And therefore, the perfusion in the glomerulus actually drops, and you can actually paradoxically worsen the state of acute kidney injury. Therefore, in a state of very bad overloads and we are acutely, aggressively trying to diurese a patient, we sometimes do not start ACE inhibitors, ARBs, or ARNIs or MRAs so early on. That being said, there are some people who believe in the vasodilator effects early on. So vasodilator effects are also important for the loop diuretics to be effective. And therefore, there are some people who believe in starting small doses of ACE inhibitors. When you actually do that, be careful about the renal function or the serum creatinine and potassium. Also monitor them very closely, because you might need to keep an eye on the spike. And if it spikes, you have to maybe cut back on the ACE inhibitor dosing. Okay, so this is the acute admission of how you would manage your RASI agents. So generally for ARNIs, because the earlier studies that got it so earth-shatteringly labeled, they were studied in the outpatient setting where patients were a lot more stable. It was only recently in the last year or so that there were new studies that showed that starting in the inpatient is probably safe, and it assists you in getting to target doses earlier. However, I think many people still are uncomfortable about starting the ARNI in inpatient setting, and probably will start them in the outpatient setting, although it's not wrong with thinking about starting the ARNI in the inpatient setting. Now, I'd like to stress that if the patient is on ACE inhibitor, and I'm referring to the column on the right-hand side, if they are on ACE inhibitor, make sure that the ACE inhibitor has been washed out for at least 36 hours first before initiating the ARNI, mainly because initiating the ARNI too early has been associated with angioedema, especially if the ACE inhibitors have not properly been washed out. Okay, so for the SGLT2 inhibitors, there's the same concerns. People are quite uncomfortable about starting them in inpatient setting, mainly because, remember, if I mentioned earlier, right, that when you are stressed out, you are at risk of euglycemic ketoacidosis. However, there were some recent small studies that suggest that starting SGLT2 inhibitors in the inpatient setting, as long as the patient is stable and defined by the previous slide, right, the BP is above 100, it's not that dependent on inotropes or diuretics, then this is possibly a time when you can consider starting SGLT2 inhibitors, perhaps just on the day of discharge or the day just before the day of discharge, something like that. Okay, so for the what to watch for, I'll let you study in your own time. And then how to monitor patients is on the last column on the right-hand side. So please study them well. And as mentioned earlier, for the setting of the beta blocker role, for example, if the pulse rate is not yet at goal, you can consider adding ivabradine, especially if the blood pressure cannot tahan. And you can think about adding digoxin if the patient has got AF. So let me explain why I use PR here rather than heart rate here. So technically speaking, right, whatever you palpate from the pulses, remember the other day in doing our practical, we're palpating for pulses. These are actually pulses that you're palpating. So by right, if you palpate through either BP meter or through taking a pulse, then those are pulse rates. The heart rates are technically what you read off an ECG. So if you recall what we did for ECG practical, we had derive the heart rate of a patient from an ECG strip, right? So that is strictly what we call the heart rate. Now, if you really want to calculate the heart rate, you should be putting a stethoscope to the apex of the heart. If you recall, the apex of the heart is where the fifth intercostal space is, right underneath your mid-clavicular line, where the intercostal space or the fifth intercostal space is, right? You would listen to the apex of the heart and you would have to count the number of heartbeats within 1 minute. That is technically counting the heart rate. I know people use the heart rate and pulse rate interchangeably today in clinical practice. I just wanted to make sure that the definitions are right for you guys at this time. Okay, so I would just like to call your attention additionally to the role of loop diuretics. You occasionally may see metolazone being added on the loop diuretic, and that's not uncommon, mainly because metolazone is used as what we call a sequential blockade effect. So if you recall where the mechanism of action of these various agents will lie, the thiazide diuretics usually act on the distal tubule, right? And so the loop diuretics act on the loop of Henle, and therefore the complementary effects is what is useful when you use them together, and it has been shown to synergistically improve diuretic effects of the two drugs used together. So remember, whenever you see people use loop diuretics or metolazone or both together, you may need to keep an eye on the potassium, because you might need to replace potassium with potassium chloride, and you would be able to see in practice that there are potassium chloride tablets that we commonly give to patients when we give them loop diuretics. Be careful if patients are renally impaired, because they cannot clear potassium as well, and therefore we may not be as aggressive as replacing potassium in a normal individual. This slide details for you from the ESC guideline, and this is really a very useful table on the starting and target doses of the various classes of agents. I do not expect you to memorize this particular chart. If anything, think about it as a reference chart. In the practice, at the start of our practice, we would generally keep this by our side, and when we get used to the titrating of our drugs, that's when we throw this table away. So essentially, remember that the starting dose is usually pretty low, particularly for the RASI agents as well as beta blockers, because you don't want to push them over to a sudden state where you cause a lot of vasodilation and therefore a plunge in blood pressure. Now, the target dose concept is something I want everyone to remember with respect to the RASI agents, particularly ACE inhibitors, ARNIs, as well as MRAs. That's something that you must aim towards and always try to strive towards that maximum dose. Whereas for beta blockers, even though there's a target dose that's associated with it, these days we go after target heart rates. And I think it's also associated with the fact that all the agents that we use can plunge blood pressure. So if we were to chase every single drug, your patients will end up with very small doses of every single one of the fantastic four, and that defeats the whole purpose of up-titrating the medications or optimizing them. The other agents that I mentioned in that list here are all the sartans in the bottom, and you can see there also that there's ivabradine doses at the bottom, as well as digoxin doses, and also hydralazine and isosorbide doses are listed over there. Now, recall that the hydralazine isosorbide dosing is multiple times a day, and as a result the compliance is very, very poor. So oftentimes my experience is really using it in people with renal impairment or people with HFpEF, mainly because the importance is to really control blood pressure. And many a times our HFpEF population also have concomitant kidney disease. So for the HFpEF population, we'll still try to use the usual drugs that we use in HFrEF, mainly because of the historical experience with them. However, for HFpEF, as I mentioned earlier, the very proven drugs of late have only been empagliflozin as well as sacubitril valsartan. But that's our scope of our lecture for HFrEF, and we'll leave it for another day.